Talk is from Mia Poleksic, from Mayo Clinic, involving insights and improved survival over time. Thanks, Mia.
Good afternoon, everyone. It is an honor to be here with you all today and to have the opportunity to present our work here in Barcelona. My name is Mia Poleksic. I am a first-year internal medicine resident at Mayo Clinic in Rochester, Minnesota, and I'll be presenting our work titled Evolving Insights and Changes in Survival of Erdheim-Chester Disease Over Time. I have no conflicts of interest. So just for a really brief amount of background, as I know all of us are very familiar with this, the BRAF V600E mutation was identified in over 50% of cases of ECD in 2012, and a few years later, the first consensus guidelines were published on behalf of researchers and physicians at ECDGA. About a decade ago, the identification of the clonal nature established ECD as a cancer and prompted advances in treatment, and a year after that, the WHO classification introduced ECD as a histiocytic and dendritic cell neoplasm. Vemurafenib was approved by the FDA for treatment of ECD in 2017. So over the last decade, a lot of advancements in both the recognition and the treatment of ECD have been made, but we have not thoroughly studied ECD mortality over time. So this study looked at a retrospective cohort of 143 patients with biopsy-proven ECD. These were adults that were consecutively seen at 3 Mayo Clinic sites in Minnesota, Arizona, and Florida between the years of 2007 and 2024. We estimated overall survival using the Kaplan-Meier method, and our data was compared to expected survival using large US Census data. And this was done using a hypothetical matched cohort by age at diagnosis, adjusted for calendar year and sex. I wanted to note that cases in their corresponding healthy cohorts were followed over the same time period to adjust for any differences in follow-up times. So as we expect, patients who were diagnosed earlier were followed for a longer period of time, so we wanted to adjust for that by following cases for the same amount of time. Risk of death was compared by date of diagnosis in 2 buckets, 1990 to 2014 versus 2015 to 2024, and we used Cox proportional hazards analysis to analyze the data. We picked 2015 as the cutoff point because this is, as I had mentioned, over the last decade, many advancements have been made in both treatment and recognition of ECD. So to look a little bit into the demographics of these 143 patients, our average age at diagnosis was 59. The newer cohort diagnosed after 2015 was just a little bit older and a little bit more male. In terms of overall percentage of males, it was about 65% of the cohort, which is in line with the ECD demographics as we know them. The follow-up of our cohort was 3.9 years, and as we expect, the follow-up of the earlier cohort was 10.2 years, much longer than the 3.6 years of the later cohort, which is why we made those adjustments in analysis. And I just wanted to highlight, as has been mentioned in the previous presentations as well, that it seems like we have gotten much better at diagnosing ECD. This later cohort has twice as many diagnoses in less than half the amount of time as the earlier cohort. So taking a look at overall survival with our Kaplan-Meier curve, I want to highlight so the line is drawn at the average of our follow-up time, 3.9 years. The solid blue line looks at the later cohort, and the solid red line looks at this earlier cohort. And you can see the difference in overall survival that we saw. But I mostly wanted to highlight the gap between the expected and observed data, and how this gap seems to close for the later cohort that was diagnosed after 2015. So to put this into numbers numerically, the 5-year Kaplan-Meier survival estimate overall for our observed data was 81.3% compared to an expected 93%. For the earlier cohort diagnosed between 1990 and 2014, it was 72.8% compared to an expected 94.7%. And for the later cohort diagnosed after 2015, we saw improved survival to 85.4% compared to an expected 92.3%. I want to just highlight why this cohort between 2015 and 2024 seems to have been, less expected survival even though it's later. We think this is because that cohort was older and had more males. So this yielded a hazard ratio of 0.44 for diagnosis after 2015, and as you can tell, this isn't quite statistically significant with a p-value of 0.057. Then we looked at total deaths during follow-up. So we had a total of 25 people in our cohort of 143 die for a standardized mortality ratio compared to expected of 2.39. The standardized mortality ratio for the older cohort was 3.06, and that decreased to 1.87 for the later cohort. So we see an improvement in this standardized mortality ratio for the patients that were diagnosed after 2015. We took a little bit of a deeper dive into cause-specific mortality and treatment history for these patients who did die. So we look at the total number of deaths of 25, and we see that about 40% of those patients who died from causes directly related to ECD. So whether this was hypoxic respiratory failure secondary to lung involvement or cardiac failure secondary to heart involvement of ECD. We do see one patient who died of a secondary malignancy, and as we know and has been discussed, secondary malignancies are very common in ECD. And 4 patients died of unrelated causes, and about 40% of patients we unfortunately did not have data on why they died, so we do not know. As expected for prior treatments that were received, for the newer cohort diagnosed after 2015, more patients were treated with targeted therapy, and for the older cohort diagnosed between 1990 and 2014, more patients were treated with chemotherapy. Patients with very limited or single organ system disease, some of them did not receive any disease-directed therapy. So our study had several limitations. It was a retrospective study design in a single health system cohort that may limit generalizability. We also, Mayo is a very large tertiary care center, so this, is subject to referral bias. Unfortunately, like I had mentioned, we have incomplete cause-specific mortality data, which makes it difficult to do subgroup analysis for cause of death, and as well as a short median follow-up time for the newer cohort diagnosed after 2015. So that cohort only had a 3.6-year follow-up time. Like I had mentioned, we had a small number of overall death events that makes it difficult to analyze death by cause of death, and our matching was all hypothetical and based on large population data from US Census data. There are several next steps where we plan to take this project. We're planning on analyzing survival, as Carla had discussed, based on treatment types, so chemotherapy versus targeted therapy, further delineating the extent of organ involvement, seeing if the patients who are dying have multi-system disease, high-risk organ involvement like we expect they would, such as CNS or brain or cardiac lesions, exploring survival based on mutation status, such as BRAF V600E or MAP2K1 mutations, evaluating the incidence of secondary malignancies. So now that we know that patients may be living longer with ECD, the impact of secondary malignancies and on survival and mortality has a potentially larger impact. And then we hope to expand this cohort to include other histiocytic neoplasms, including Langerhans cell histiocytosis and Rosé-Dorfman disease. So in conclusion, over the last decade, we have redefined ECD as a clonal hematopoietic neoplasm that has specific molecular targets for therapy. And at least in our very preliminary data, these advancements appear to have lowered mortality rates, at least for patients diagnosed after 2015. And this is important because it may lead to a paradigm shift in how we discuss this diagnosis with patients. Now that we see that mortality rates may align more closely to the general population, it really emphasizes the importance of preventative care, secondary cancer screening, and cancer survivorship strategies. And as we all know, our patients with ECD, though they may be living longer, still have a significant burden of symptoms and an impact on quality of life. So focusing on quality of life and holistic patient support for patients and their caregivers will be more important than ever. I wanted to say a big thank you to our team and our wonderful co-authors, and a particular thank you to my mentor, Dr. Abe Kuhn, who is here today, and the Mayo Clinic Histiocytosis Working Group that has made big advancements to this field, and of course to all the patients and their caregivers. Now we'll open for questions.